Hello, everyone. First of all, I would like to thank the Pediatric Trauma Society and the Program Committee for the privilege of presenting our work. We have no disclosures to make. Blunt cerebrovascular injury, BCVI, is defined as any injury to the carotid and/or vertebral arteries following blunt trauma to the neck. These injuries appear to be uncommon in children, where in the review of the National Pediatric Trauma Registry, Liu et al. Reported an incidence of 0.03% in pediatric blunt trauma patients. More recent studies have reported incidence rates ranging from 0.3 to 0.9%. This low incidence could be related to either underdiagnosis of injuries or actual decreased incidence compared with adults due to children's innate protective physiological differences, such as the lack of atherosclerotic disease and increased vascular elasticity. Therefore, the aim of our study was to examine the incidence, patient characteristics, and risk factors associated with BCVI in pediatric trauma patients on the national level. For that, we performed a one-year analysis of the 2016 KIDS database. We identified all pediatric patients presenting with blunt trauma, and we excluded patients with penetrating injuries and transfer patients. Our primary outcome measure was ischemic stroke, and our secondary outcome measures were in-hospital mortality and hospital length of stay. On to our results, we identified more than 80,000 pediatric trauma patients. The vast majority were blunt trauma, more than 90%, and only 0.7% had a diagnosis of BCVI. This was further classified according to the patient's age group, and we found that the majority, more than 78%, were between 15 and 20 years of age. When examining the differences between the two groups, patients with the diagnosis of BCVI were more likely to be older and with more severe head and neck injuries and higher overall injury severity scores. BCVI patients were also more likely to present with motor vehicle collision and as pedestrian struck patients. When examining our primary outcome, patients with the diagnosis of BCVI had significantly higher rates of ischemic stroke and suffered a significantly higher in-hospital mortality and were hospitalized much longer than patients without a diagnosis of BCVI. When examining risk factors for BCVI in our patient cohort, we identified motor vehicle collision and pedestrian struck as the two most common mechanisms of injury associated with BCVI. We also found that cervical fractures, skull-base fractures, and intracranial hemorrhage to be the most significantly associated injuries with BCVI. In conclusion, BCVI in pediatric trauma patients is associated with increased ischemic strokes, mortality, and hospital length of stay. We identified risk factors for BCVI as high-impact collisions, cervical and skull-base fractures, and intracranial hemorrhage. Therefore, targeted screening remains necessary to diagnose BCVI early on and initiate treatment to avoid undesired outcomes. Finally, I would like to thank the Division of Trauma and Acute Care Surgery at the University of Arizona and my mentor, Dr. Joseph, for their continuous support. Thank you.